I see that we have quorum. I declare this meeting in session. I am Mubina Jaffer, the Senator from British Columbia, and I have the pleasure of chairing this committee. Today we are conducting another hybrid meeting, the last of our 5 days of marathon hearings. Thank you again, Senators, for your patience as we adapt to this new way of holding our meetings. As I said earlier, Senators, we have truly run a marathon this week with 81 witnesses, and we have tried to achieve a balance and heard from all witnesses from all points of view. Senators, thank you very much for your support. And I also want to thank the clerk of this committee, Mark Palmer, and the great team he has behind him that has been supporting us through this very quick and really a big task to have 81 witnesses in front of us in 1 week with very little notice. I would like to thank the clerk and his team on all our behalf. Je vous rappelle que lorsque
I would like to recall that when you're speaking, you need to be on the same channel as the language that you're going to speak.
to just refresh our memories that it's 4 minutes per member for questions. And I will really do my very best to get through all of you. It is now my pleasure to welcome our first panel for this morning with Dr. Sonu Gaind, Associate Professor of the University of Toronto, and Dr. Scott Kim, Senior Investigator, Department of Bioethics, National Institute of Health. Je voudrais prendre quelques minutes.
I'd like to take a few moments to present to you the members of the committee who are participating in the meeting today. Deputy Chair Senator Batters.
Senator Campbell, Senator Boyer, Senator Carignan, qui est la critique du projet de loi.
Who is the shadow for the bill?
Senator Dalphon, Senatrice Dupuis,
Senator Dupuis and Senator Boisvenu.
Senatrice Petitclerc, la marraine du projet.
Who is the sponsor of the bill?
Senator Plett. And we also have joining with us today Senator Kutcher, Senator Pate, Senator McCallum, Senator Julie Millville-Deschênes. In the name of the members, I would like to welcome you all, and I would like to tell the panelists that we are really looking forward to hearing from you. I know that you had to prepare in a short time, and we appreciate your effort. We will start with Dr. Sonu Gaind. Doctor? Doctor, you are muted.
Okay,
Thank
can
you.
you hear me now? Okay, perfect. Thank you, Senator. My name is Sonu Gaind. I'm an associate professor at the University of Toronto and chief of psychiatry at Humber River Hospital. My clinical expertise is psycho-oncology, and I'm the physician chair of our hospital MAID team. Thank you for this opportunity to present to you. Mental illnesses afflict up to 1 in 5 Canadians every year, with 8% of adults experiencing clinical depression at some point in their lives. Mental illnesses change how a person thinks and feels and can be as grievous and intolerable as any physical illness. Yet Bill C-7 proposes excluding mental disorders as the sole basis for MAID. Why? People have diverse views on MAID. All opinions should be respected, but any compassionate society should set policies based on the best available evidence. We need only look south of us to see what happens when wishful thinking and ideology drives policy. And no matter how many times an evidence-free opinion is repeated, it does not transform it into fact. Here's the evidence. MAID in Canada is based on having a medical condition we can predict in advance as being irremediable. The fact is, we do not know how to predict irremediability in mental illness. Some have suggested the unpredictability of mental disorders is no different than that of physical disorders. This is simply untrue. The disorders before the courts that all MAID rulings are based on are far more predictable than mental disorders. While some other physical disorders can be unpredictable, expansion advocates rarely point out the simple fact that we do not understand the pathophysiology of almost any mental disorder. It's a false equivalence to equate the unpredictability of illnesses like cancer, neurodegenerative diseases, or disorders with known underlying biology with mental illnesses that we lack fundamental understanding of. So if those with mental disorders would not be getting made for something we could, with any honesty, predict as irremediable, what would they get made for? We know psychosocial suffering increases both the risk of getting mental disorder and the suffering from it. We know that unique to mental disorders, suicidality, guilt, and hopelessness can be symptoms of mental illness. While people can feel suicidal for various reasons, no physical illness I'm aware of has the wish to die as part of the actual diagnostic criteria. Expansion advocates fail to point this out when they call for everyone being treated the same. They also assure us that vulnerable groups do not disproportionately seek MAID. While true for North America, where there is an equal gender balance and those seeking MAID tend to be better off, well-educated, and also Caucasian, that is when MAID is for those who are dying, people who have lived well and want to die well. Evidence shows it is a different group who seek MAID for mental illness, with twice as many women as men in those situations seeking MAID, and patients suffering from unresolved psychosocial stressors. That's some of what we know. What about what we don't? Evidence shows we do not know how to distinguish between those seeking MAID for mental illness from patients with suicidality as a symptom of mental illness. In short, evidence shows that there are significant differences with mental disorders that warrant treating them differently for MAID. Failing to do so would be discriminatory. With all these realities, as recent past president of the Canadian Psychiatric Association, it's been highly disturbing to me that the CPA has taken a position without any member engagement or evidence, suggesting it would be discriminatory not to permit MAID for mental illness. Remarkably, they have done this while admitting they have not reviewed how or whether irremediability can be identified. Talk about putting the cart before the horse. Some are suggesting the issue is simply lack of consensus and proposing a sunset clause on the exclusion of mental disorders to allow time to develop standards. The issue is not lack of consensus. The issue is lack of evidence. Lack of evidence about whether irremediability in mental disorders can even be predicted. If CPA is putting the cart before the horse, a sunset clause would be putting the cart before the horse without even knowing if the horse exists. We talk about the terrible stigma and discrimination faced by those with mental illness. This is not a reflection of our friends and loved ones being weak or inferior. It's a reflection of us as a society implementing discriminatory policies and turning a blind eye to the realities of mental illness. Pretending there are no differences between mental illness and physical illness for the purposes of MAID borders on, and I think I'm qualified to say this, delusional. And it's not about infantilizing anyone or removing their autonomy. People themselves wish to continue living when they improve. It's about avoiding discrimination by ensuring we don't set evidence-free policy exposing our loved ones to arbitrary assessments with no standards that can lead to their premature deaths. I've limited my opening remarks to 5 minutes. You'll see in my brief, I have 6 specific recommendations, and I look forward to the chance to speak to those in the question and answer. Thank you.
Thank you very much, Dr. Sonu Gaind, and we appreciate your presentation. We will now go on to Dr. Scott Kim.
Thank you, Senator. It's a real privilege, and I really appreciate this opportunity to speak with you. I was told that my initial comments could be 10 minutes, so that's what I'll keep to. I submitted my speaker notes in PowerPoint form. The first 3 pages are just background. And I should only note that I represent myself as an individual and researcher, not my employer in any way. I think that's very important to note. I will start with slide number 4 if you happen to be following, and I'll go from there. The first point I'll start with this issue that in somehow psychiatric made, that's the term I will be using for what we're talking about, so that it'll be quicker for me to refer to it. Is this some type of a cutting edge human rights cause? I would say it's no, it's the opposite. I just bring attention to the fact that Australia and New Zealand have both recently passed laws
Dr.
permitting
Kim, we
MAID,
just have to
but
stop for a second. I don't think we have translation.
it's not, is it because of my audio or?
Let's try again, Dr. Kim.
Okay. Can you hear me okay? Are you able to hear me? I'm not given a go ahead here. Should I?
We're just going to suspend the meeting for a minute. Senator Jaffer, can we suspend for a minute while we try and work out the audio?
Yes, absolutely.
Can you hear me okay? Should we start from the beginning?
I might as well. I don't know how much the interpreters were able to interpret. So start from.
Okay, thank you. Thank you. Thank you so much for this opportunity to speak with you. It's a real privilege. I have submitted my speaker notes in PowerPoint form. I will start with slide 4. The only thing of true relevance in the first 3, which describes my background, is that I am speaking only as an individual citizen and researcher, not in any way representing my employer. So I will start with slide number 4, which which is the very first point I'd like to make, which is that I'm going to use the term psychiatric MAID as a shorthand because I've been asked especially to bring some international as well as specific focus on MAID when it's performed primarily or solely on basis of a psychiatric disorder. Is this a cutting edge human rights cause? And I would say it is the opposite. Because the reason why I say that is because Australia and New Zealand recently passed laws that permit MAID, but in those laws, they specifically and explicitly exclude MAID that is based solely on psychiatric disorder or disability. UN Special Rapporteur's report in 2019, which they submitted to the Human Rights Council there, also is consistent with this view. And I should add that psychiatric MAID has low approval even when it is, even in places where it's permitted. Only the minority of Dutch public, medical doctors, including psychiatrists, approve of the practice. And similar data can be found in Canada as well. Why is this the case? Well, I think that Dr. Gaind has already briefly alluded to this very powerfully, but let me just say that it's because end-of-life MAID and psychiatric MAID involve fundamentally different decisions. End-of-life MAID is an exceptional approach to a universal experience, that of dying. And it's an approach taken by, it should be said, based on data, that it's among the relatively privileged in wealthy countries. And these are folks who actually want to live. I'm going to repeat that. For by and large, these are people who want to live, who, dying, want to choose how they die. Contrast that with psychiatric MAID, in which we're talking about a subpopulation of people with mental disorders who feel they do not want to live. even though they are not dying. Such persons have always been regarded as highly vulnerable and deserving special resources and protections in civilized societies. And this is why these new laws, as well as the UN's human rights experts, have tried to protect this group. Also, it's important not to project data from the former end-of-life MAID practices and try to project it into what would happen with psychiatric MAID. This is an incorrect use of evidence. I would also like to point out that I'm speaking to a difference between instance and population. Good policies are not based on idealized, especially difficult or gray area instances. What I will be speaking to is the effect of the practice on the population, hopefully using direct data as available that's out there. And these are data from the Netherlands where actual practice of psychiatric MAID occurs. And I should note that the Netherlands is a useful test case because they have excellent accessible healthcare, as well as having a more transparently regulated MAID review system than other countries. So what do we find? Who requests and receives psychiatric MAID? Mostly the same group of persons who mental health professionals are careful to monitor and treat for suicidality. People with personality disorders, majority have personality disorders, depression, trauma histories, anxiety disorders, people who need support to shore up their coping skills. These majority are socially isolated and lonely. These are some quotes made by doctors who provided euthanasia to these patients. Quote, the patient indicated that she had had a life without love and therefore had no right to exist. Quote, the patient was an utterly lonely man whose life had been a failure. Most of these patients also have had history of suicide attempts. And 70+% of people who receive psychiatric MAID are women. This is a robust, consistent finding across countries over time. And this is the same ratio as suicide attempts in people, where attempts are 2 to 3 times higher in women in these countries, whereas the completion rates are higher in men, which reflects the fact that we're talking about a population at risk for suicide. Psychiatric MAID will involve unanticipated situation, as in the case of a healthy woman who received euthanasia for prolonged grief disorder 12 months after her husband's death, based on the diagnosis of prolonged grief disorder. This disorder does not appear in DSM, but it is a much studied currently disorder. Complicated grief is much studied. And there's dispute about how long you have to have the symptoms. Some experts believe you need 12 months of symptoms. So there was really no science to support the view that her condition was irremediable. I'm just giving you that as a particularly striking instance. Over a quarter of the psychiatric MAID occur in people with some form of psychosis. And surprisingly, autism spectrum has become a relatively common basis for MAID in Belgium, for instance, up to 19% in a series of 100 patients. Will capacity evaluations be rigorous? When we're discussing prospectively what it should be like, people say it must be rigorous. But if you look at the practice, doctors exercise tremendous leeway. In our study of the cases, we found that over half the time, doctors simply assert that the patient is competent. So for example, even in the following case, that's all we saw. Woman in 70s, schizophrenia since childhood, who felt, quote, her head was continuously occupied by voices commenting on everything and commanded her to do things. She felt like she was staying in some sort of labor camp and was possessed by the enemy, end of quote. Neither her PCP nor psychiatrist would agree to performing MAID. She received it at a specialty clinic dedicated to the practice. We also found instances where doctors acknowledge that a patient doesn't have all the abilities relevant for capacity, but they still deem them competent and go ahead with MAID. Irremediability, a highly important, crucial criterion, even when it is an objective medical criterion where people have to go through reasonable treatments as in the Netherlands, 56% refuse it, yet are provided MAID. 20% are never hospitalized. And when we look specifically at people with personality disorders, because they're such a prominent group, we find that subspecialist involvement is rare, either in treatment or evaluation. Over a quarter, 28%, do not receive what we would consider standard treatment, which in personality disorder is psychotherapy. Case reports don't reference data or scientific studies about irremediability in these reports because science is thin and is not supportive. It's largely done based on clinical impressions, quite frankly. So now turning to Canada, if irremediability is subjectively defined as in Canada, functionally, I think it's important to note that this makes the doctor or a healthcare practitioner an instrument of a patient's suicide without fully addressing what makes the patient so vulnerable when they perceive things like, quote, I won't get any better, my life is worthless, there's no other option, etc. This is a very stark conclusion and implication of the, if it is legalized with the current settings. Psychiatric MAID requests are not stable. And I presume somebody has presented this, but in the case series of 100 people who were deemed competent and tolerated suffering due to refractory conditions, 38% withdrew requests, and after 1 to 4 years of follow-up, 57 were still alive. And note that 48 patients were described as managing with regular, occasional, or no therapy. And these are persons who were deemed at the beginning competent and tolerated suffering due to refractory conditions. Doctors, it's not a surprise that doctors disagree about eligibility. And what eventually happens is that because only a minority of doctors are willing to do it, the practice funnels to those doctors with the minority views. So in the cases that we described, close to a third had been refused in the past. And even in cases where they are performed, what happens is that a quarter of the time there's disagreement outstanding, but in half those cases, the general practitioner's view is taken and accepted over the psychiatric consultant's opinion. It has gotten to the point where over 9 out of 10 psychiatric MAID cases in the Netherlands occur in specialty clinics whose only purpose is to perform MAID with no prior relationship with patients and no palliative care or other treatments offered. So in actual practice, what the psychiatric MAID asks doctors to do? Well, they have to do one or the other: prevent suicides of especially vulnerable patients, or provide a definitive means of ending the lives of those same vulnerable patients. And to do so based on clinical and personal impressions, not scientific evidence, applying broad legal, not clinical criteria that are well-defined, which are not well-defined, by providers and doctors with views, I would remind you, at odds with majority of their peers, the public, and UN human rights experts. So in conclusion, recalling that, some people say, well, Netherlands is not, generalizable to, I would say these are the actual cases. This is the best data we can have currently, because this is about people who receive it. In a setting where it's more closely monitored with more resources. If this is legalized in other settings, I would say the following conclusion is a very reasonable one, that there would be significant risk of wrongly ending lives of many patients because either they're not competent or
Dr. Kim,
they don't suffer
you
from
moved your mic just too far away.
I'm sorry. I would repeat that. Given the above evidence, legalizing psychiatric MAID in Canada would significantly risk wrongly ending lives of many patients who are not competent or suffer from a remediable situation, disorder, or perception, or who would have changed their minds about MAID with time and treatment and regained meaning and will to live. Thank you very much.
Thank you, Dr. Kim. We will now go on to questions, but before I do that, Senator, I neglected to mention 2 senators who are also on the committee with us. Senator Boyer and Senator Frum are also here with us. And so we will go on to the first question from Senatrice Chantal Petitclerc, the sponsor of the bill.
Merci beaucoup, Madame.
Thank you, Madam Chair. I have a question for Dr. Gaind first. And if we have time, I'll ask the same question to Dr. Kim. And here's my question. We have heard this week many witnesses about worries concerning mental health. I would like to quote Dr. Gupta, who said a few days ago, we already examine consent capacity to MAID for people who have mental health disorders and physical health disorders. We would need to find a good reason to not apply it if it was just for mental health disorder. So I'd like to hear you on that. What would you reply? Maybe Dr. Gaind first.
Oh, we can't hear you.
Shipa, I did not have the translation, so I will try to do my best. I believe you were asking about comments that Dr. Gupta may have made regarding how we already assess capacity in challenging cases.
Exactly. Yes, and allow me a spontaneous translation here. So basically, if we are able to assess capacity when it is not only a situation of mental illness, we should be able to do it when it is only mental illness that is in the case. And I wanted to hear you on that.
So thank you for the question. My background, as I had mentioned, is in psycho-oncology. So I deal with dying patients. I deal with patients who may have both end-of-life issues and cognitive issues. And in psychiatry, and especially in consult liaison medicine, we do frequently assess challenging cases of competence and capacity. So that is true. That is something that is part of our skill set. Now, that does not necessarily mean that it translates one for every MAID assessment. And part of the reason is that capacity is not a global issue. We don't determine that a patient either is fully capable or not. It is case by case for the decision being made. And so one of the things to remember is that the decision being made for MAID is when somebody no longer wants to live. And there are multiple reasons that someone may not want to live. In the current MAID framework, when death is meant to be reasonably foreseeable, and in any of the terminal MAID frameworks, typically what we see is that people want MAID to avoid a painful death. As we expand the criteria, and once you drop reasonably foreseeable natural death, and you look at other conditions, all sorts of other life suffering comes in. And then we find that people want death to avoid a painful life. And that introduces an entire different complexity when we're trying to weigh how cognitive distortions of depression can impact someone. Those are things which make me feel the world is terrible. My future is terrible. I am terrible. I'm a burden on my family members and loved ones. I'm worthless. So just imagine how that might influence your decision about whether you want to be here or not. It is very different than saying, do you want to take a pill or not? Or do you want to engage in, an exercise program or not?
Yeah. Jaldi.
Did that address your question?
Dr. Gaind, just before we go on, this is the clerk here. For your interpretation, on your Zoom screen at the bottom right, there should be a button that says interpretation, and you can choose the English or the French channel there.
Je la trouvé. Merci. Thank you.
Perfect. So if you put it on English, you should now get the English translations.
Okay. Thank you.
Senator Petitclerc, we will come back to you in the second round. We maybe now go to Senator Claude Carignan.
Oui, merci.
Thank you. Can you now hear the interpretation?
Yeah,
Parfait.
thank you.
So my question is for both of you, and it is about how to define mental illness. In the bill, mental illness is defined. Dr. Kim, you talk about psychiatric disorders, mental disorders. So for you, mental illness, is it clearly defined, or is the definition clear enough, rather? Dr. Gupta said that the definition was not clear enough. The situation that you talked about, and especially when it's psychiatric disorders, that seems to be more precise than just mental illness in general. So could you say something about that?
Would you like me to go first?
Wait.
Dr. Gaind?
Yes.
Okay. I think this speaks to Dr. Gupta's point. I think, as I understand it, is that there's a lot of comorbidities, for instance, between patients who have serious somatic illnesses as well as psychiatric illnesses. And how do you know when they ask for MAID, what is the basis and so forth, for example? I think that would be a kind of a very practical implication of what you're asking. So I guess I would just reply by saying that I was able to do the research that I spoke to you about from the Netherlands, where they permit what I call psychiatric MAID, and the doctors and the review committees have separated out those cases that they consider them. As far as I know, there are no prominent disputes about their ability to do that. And because they're able to do that, we were able to do the study. So from my experience of in a jurisdiction studying the practice, this is not every category has boundaries and gray area cases, and that should be acknowledged. But my experience is that this is not a prominent difficulty.
And
Dr.
if I can,
If I could ask before Dr. Gaind, I am not speaking about comorbidity between mental illness and physical illness. I'm talking about when there's only mental illness. This idea or concept of mental illness could cover a lot of things. And maybe it's not precise enough.
one of the challenges that arose, and maybe Dr. Gupta was referring to, was that would we consider things like dementia a mental illness for the purposes of this exclusion or not? And that's really, in terms of the practicalities of the question and answer, I think probably the most significant thing, because aside from a few areas like that, I would say that there's quite a good definition of what we'd be considering as mental illnesses. You're speaking of mood disorders, anxiety disorders, psychotic disorders, personality disorders, all sorts of disorders. And in North America, we use what's called the DSM. Rest of the world uses ICD. And there's significant overlap between those diagnostic criteria for mental illnesses. And interestingly, the ones that are probably most relevant to your question, again, the neurocognitive or neurodegenerative disorders, dementias, for example, those also exist in neurology diagnostic classifications. It's been an interesting sort of ball. Which court is it in? Is it psychiatry? Is it neurology? The difference with those is that you do tend to have a much better ability to predict the irremediability or course. Alzheimer's is not going to reverse itself and simply disappear. So what I would suggest is that, yeah, you can say, we can quibble about, are there little things on the boundaries, but at the end of the day, the practical ones are quite well defined. And keep in mind that when we look at MAID in jurisdictions that allow it for mental illness, the majority of people get it for exactly what you expect they probably would, which is mood disorders and depression. And then there is a smattering of others as well, some of which are concerning diagnosis for people to receive MAID for, like personality disorders.
Thank you, Dr. Gaind. We'll now go to Senator Campbell. Senator Campbell?
Thank you,
Senator
Chair.
Batters.
I have no question at this time.
Senator Batters.
Thanks
Senator
so much.
Batter.
Yes, thank you. Dr. Kim, your presentation mentioned a study showing that 70% of those accessing a psychiatric MAID are women. And this is the same ratio of women attempting suicide, which is about 2 to 3 times higher than men. And the stats also tell us that women are far more likely than men to attempt suicide, whereas men are more likely to die by suicide. And that's generally because men choose more lethal means. But with access to MAID, we would be giving women the more lethal means to suicide, where there's no second chance to get some good psychiatric treatment finally and hopefully improve the condition. Could you please elaborate on that point?
Thank you, Senator. I think you have actually summarized it quite well. In fact, we have a paper under review right now on this very question, because what we've done is to review this suicide literature as well as the MAID literature to try to understand why is it that it's I have to say, it's one of the most robust and consistent findings in this literature is the 70 to 80% of the psychiatric MAID cases being women. And it has to do, we believe, with the fact that if you look through the lens of who are people who are at significant risk of suicidal thoughts and suicidal attempts, it is women far outnumber men. And when we look at the personal histories of many of these patients, the kind of things that lead to a life with difficult to treat mental disorders, personality disorders, and so forth have to, we often find only women, men and women both get PTSD, but it's the young women as they age with sexual abuse histories, for example, trauma histories, which is prominent. So, and we know that mood disorders are more common in women, for instance. That adds to the issue. But we don't know why it's more common in women than men, for instance, because we also know that this is of interest to WHO. Why is there these disparities of women having these mental disorders that seem to have preceding social conditions that make them more vulnerable to? So when you put all that together, it is a bit of a worrying picture that, and of course, we're talking about populations. And
yes.
I'm sorry?
I'd like to go on to my second question, if I could.
I'm sorry.
It seems that
Yes.
Some people this week, we've heard this, have moved past the discussion of whether to include mental illness as a sole underlying condition for MAID and are no longer discussing whether, but when. And based on the testimony we've heard this week, this seems shockingly premature. And do you think, Dr. Kim, there is any level of consensus in the psychiatric community that would justify a sunset clause, as some have proposed, and which would put an end to the exclusion of mental illness on a specified date within C7?
I can't think of any professional consensus nor scientific basis in which you could, I don't know what the future holds. I'm not sure, given the best available direct data on the cases that you just heard from me. I don't know. I quite frankly, I have not heard about the sunset clause idea until recently, and I have no idea how one would justify that on any kind of scientific or professional consensus basis, or indeed on human rights basis, as I noted.
Thank you.
Dr.
Second
Kim.
round, please.
Senator Delfont. Senator
Yes, thank you. Yes. My question is for both, but maybe I'll start with Dr. Kim. In your presentation, you referred to New Zealand and Australia. That's not my question, but just want to comment that they have no Charter of Rights in Australia, and the New Zealand Bill of Rights does not give the authority to the court to strike a law. So it may be slightly different legal context than Canada. But that being said, facts are facts and evidence remains the same. On page 14 of your presentations, in your conclusions, you really say the last paragraph is very interesting. And does it really, you say that some people, if we open it to psychiatric or mental illness, if we open MAID to it, some people will be provided MAID that are not competent, will not suffer from irremediable situations, or people that will have changed their mind. These three caveats that you're making, aren't they a sign that the psychiatrist or the profession, the medical profession, is unable to assess properly competency, the remedial character of illness, and the ability of the patients to consider other options?
I think your question was, why aren't doctors competent to actually do those three things so that they
I'm
can
not saying
provide
they are
rigorous
not,
safeguards?
I'm not saying they are not competent, but you seem to question their competency to apply the criteria.
Yes. No, so I think I would make a distinction. I'm not saying that, well, I am saying this, even when they try their best, they fail. That's what I'm saying the data show. So why is that the case? It's because competency evaluation is an art, number one, that you have to use very broad criteria, and people have different views about it. And there is a recent paper from Belgium that says that when they interviewed neurologists and psychiatrists about their training and competency evaluation, they say, well, we never really got formal training. And they all had different views about how to do it. And the paper concluded by saying, well, to get rid of these arbitrariness, we're going to have to do X, Y, Z. So that is the state of the art. The remediability, of course, is that we talked about the science. There isn't there.
Okay. Can I ask also the same questions to Dr. Gaind, who's the former president of the Psychiatrists Associations?
You are muted, doctor.
In terms of the main, I think the most relevant part of that as far as MAID assessments goes, there are no criteria for identifying irremediability. And the fact that we cannot predict it, that doesn't reflect that people aren't applying some kind of standards properly. There are no standards. And on top of that, we don't know whether there can be, because of the inherent unpredictability of mental illnesses being potentially different than physical illnesses. This is part of the problem, and it does actually loop back to the previous senator's question as well about whether there should be a sunset clause. You know, a sunset clause would be presupposing the outcome of us determining whether irremediability can be predicted. And we don't know that yet. It's not that the CCA, I sat on the CCA expert panel as well as Dr. Kim, and it's not as if we didn't look at this. We did look at this, and we could not find, not even a consensus, any evidence of being able to predict irremediability. And CAMH, which is probably amongst the, if not the most respected, non-partisan organization, has weighed in on this matter and has specifically said that you, at any point in time, it may appear that an individual is not responding to any interventions, that their illness is currently irremediable, but it is not possible to determine with any certainty the course of this individual's illness. There is simply not enough evidence available in the mental health field at this time for clinicians to ascertain whether a particular individual has an irremediable mental illness. And I won't take more time in answering the question here, but I will direct you to some of the material that I had forwarded in my brief. And I would specifically ask you to look at the case report, which is presented by Dr. Dembo, who was one of the witnesses earlier, who is a strong advocate for expanding MAID. And please read that case report of a patient who she had essentially thought could not get better after even an extensive literature search. And the person did resolve, was then glad to be alive. And Dr. Dembo concludes that piece saying, in the end, we were wrong in our assessment of her not being able to get better, but we could not have known at the time. That is the state of science.
Thank you, Doctor. We'll now go to Senator Plett.
Put me on the second round. Thank you.
Thank you, Chair. My first question is for Dr. Gaind as well, and I do have a question for Dr. Kim if I have the time. Dr. Gaind, in addition to being a psychiatrist, and you have spoken about this briefly, but I'd like a bit of a better explanation. In addition to being a psychiatrist with clinical expertise working with cancer patients and end-of-life issues, you are also a recent past president of the Canadian Psychiatric Association. You are not a conscientious objector, and you were heavily involved in the initial work the CPA did when assisted suicide policies were unfolding. Yet now you are, I think, rightfully critical of the CPA's current position. Can you elaborate why and what change took place?
Thank you, Senator, for the question. I will preface this by saying and acknowledging this is a difficult issue for me to talk about. I have spent, along with many colleagues, many hours working with colleagues across the country in CPA and other groups. We've always followed processes that seek to engage both our membership and external stakeholders. That did not happen with the development of the CPA's position, and it frankly shocked me. You heard testimony, I believe, on Monday from CPA itself, stating that they've been engaging members. I believe this was in response to a question about how representative their current position is. And the response was that they've been engaging members and stakeholders since 2016 with surveys and symposia, et cetera. I know this well. It's true that between 2016 to 2018, when I chaired the time-limited CPA task force on MAID that did this work, we did engage members in surveys and participated in symposia, et cetera. However, after that task force was sunset in 2018, there was literally zero engagement. And then 2 years without any engagement, CPA released its current position. You heard on Monday that they've surveyed members again and that they've conducted town halls, and that is true. However, there were no questions or ability to give feedback on the CPA's position. That was strikingly absent from the survey questions, and the town halls only sought feedback on the same survey questions. And more concerning, the CPA actually rejected several members' requests to have MAID on the agenda at their recent AGM. So to this day, CPA has not asked its membership what they think about the CPA position. It has also not engaged any stakeholder or expert outreach. There's been no input from those with lived experience. No Aboriginal or other cultural consultations were sought in developing this position statement. And engagement and inclusion, if there's one thing we're learning with events around us, engagement and inclusion need to be more than just buzzwords. They need to be reflected in actions. At the recent AGM, it was pointed out that while there has been good diversity of elected members up to the board and president who are all elected by membership, we have not seen that diversity in senior appointments. CPA is a national association with offices in Ottawa, yet in its over 60-year history, it has never had a visible minority as a CEO or chair. So in terms of engagement and getting diverse views to have input into the CPA position statement on MAID, I can very regretfully tell you that that has not happened, and it deeply saddens me.
Thank you. Very quickly, Dr. Kim, do you think an assessment of capacity for decision-making and informed consent is sufficient as a safeguard in the context of assisted suicide, and why or why not?
It's hard to answer in a brief period. I think that as a clinician who wants to be very sure this is truly the authentic wish of the patient, considering all the relevant factors, I think it's a necessary but insufficient.
Thank you, sir.
Thank you, Chair.
Thank you, Senator Platt. Senator Boyer. After Senator Boyer, Senatrice Dupuis, and then Senator Keating.
Thank you, Madam Chair. My question is for Dr. Kim. In Canada, Indigenous people have experienced racism and discrimination when accessing healthcare services. As you may be aware, there are instances when an Indigenous person has been targeted and forced to have procedures against their will, such as forced sterilization. If an Indigenous person goes through the MAID process, they are likely to interact with non-Indigenous healthcare providers who may or may not be trained to provide culturally safe healthcare. We heard yesterday that additional safeguards must be in place to ensure Indigenous patients do not feel any pressure or coercion from practitioners. Given your experience in ethics and decision-making capacity, what safeguards are necessary to protect the autonomy of patients in the decision-making process as it relates to MAID?
This is such an important question you're asking. Senator. It's so important. And the only true safeguard would be to ensure equal, excellent access to healthcare in a culturally sensitive setting that's no different from any privileged person who lives in the highest privileged area of Canada. I think if you could guarantee that, then I would say you've taken a crucial, necessary step. But if that is not a reality, I don't know how reliably a isolated decision-making capacity assessment can truly address what is a huge systemic issue.
Thank you, Dr. Kim.
Thank you, Senator Boyer. We'll go to Senatrice Dupuis and then Senator Keating and then Senator
Merci. Ma première question.
I have a first question for Dr. Kim, and the second one is for Dr. Gaind. Dr. Kim, you've given us statistics about the Netherlands. I don't know to what extent the statistics and this research took account of sex or gender-based analysis. We've seen in the statistics that you've shown us that there are many more women involved. Can that be explained by the fact that there's more women who go for consultations compared to men? And we will recall that quite recently, there were more women that were institutionalized just at the request of their husbands. So there's contextual studies that need to be carried out to justify the data that we're faced with today. And I'm not certain that I've seen that in your documents. So my question for you is, are you aware of the experiment that's been carried out in Quebec over the last 10 years? What's your knowledge of Quebec? And do you know about the recent report from the Quebec Psychiatrists Association on mental illnesses?
Senator, and if you would like me to comment on and send me separately, I'd be happy to read and give you my understanding.
Est-ce que le Dr. Gaind?
Dr. Gaind, could you answer my question? And I'd like to say to Dr. Gaind and Dr. Kim that we share with you the impression that these are very, very difficult and sensitive matters. I share that feeling with you because for 10 years now, I've been involved in this type of discussion in a very involved way. So I think that all of us who are dealing with these matters, who are trying to navigate these subjects, are confronted with the difficulty of these matters. So I have a question for you, Dr. Gaind. It's very important what you've said about the fact that there's no criteria to judge that the condition is irremediable, and we cannot predict with mental illnesses how it's going to actually evolve. My question for you is the following, therefore. I don't know if you're aware of the Quebec experiment with this, but would you accept that in the patient-physician relationship, there has been an important evolution where perhaps the power relationship is now more equal, and we've arrived at the conclusion that with a range of solutions, the patient's decision has to be respected by the physician. Do you share that point of view, Dr. Gaind?
I unequivocally 100% share that point of view. There has been a necessary rebalancing of the contextual relationship between, and some people call them patients, but, patients and whether it's physicians or any healthcare providers. Now, having said that, so that has to do with respect and autonomy, and also in equalizing or as best as possible and improving of that balance. Having said that, no one can know the unknowable. And just as I am frankly not competent. You know, I as had come out earlier, I'm not a conscientious objector. I chair our MAID team in the hospital, but I don't feel competent at making irremediability assessments for illnesses that are outside my wheelhouse. So I don't make that assessment of irremediability because they're not mental illnesses that are being categorized as irremediable or not. I can't make an assessment of whether a mental illness is irremediable.
C'est pour ça, justement, que j'apprécie votre candeur à le reconnaître.
That's why I really appreciate your comments, Dr. Gaind, and that is why I'm putting the question to you about the fact that you're unable to do this personally, and also the medical corps is unable to do this. So do you really understand why I'm insisting upon the fact that I want to have the wish, the choice at the end of the day, because there's real nothingness from a medical point of view on this?
I think I do, Madam Senator. And what I would suggest is that if we are saying that the foot in the door in our MAID framework is an irremediable medical illness, and if we can't demonstrate that it is predictably an irremediable medical illness, we can't go through that door. But if society, and I personally am not saying I'm in favor of, but if society were to say that, look, we're changing that. It's not about irremediability, but it's about us thinking you've suffered enough, even if you might get better. That's a different equation. That's a different social contract. That's not the discussion we have had with the country. And if that is the decision and the will of the people to go in that direction, we should have that debate. We should not try to pretend it's about something it's not. That's my concern.
Merci, Dr. Gaind.
Thank you, Doctor.
We have a challenge, and I want a decision from you. And there is the next witness in the next panel that may not be able to be heard because he doesn't have a mic. And so there is still people that are still on the first list, and also we have a lot of people who have second round and I would like to give them the opportunity. If one of the panelists in the next panel is not successful, can we please stop for few minutes, check his mic again, check with the interpreters if he can be heard, because I'd really like to give the opportunity to people who have a second question, and also we have 2 senators from the committee who still have not asked questions. So can we suspend for 2 minutes? Yeah.
For Dr. Gaind, thank you very much for your presentation. I thought it was very helpful. Doctor, the bill itself states the following, that a mental illness, and it's not defined, but it is excluded, of course, and it says a mental illness is not considered to be an illness, a disease, or a disability. Now, that's a very, very broad brush of exclusion. And you've heard Dr. Kim say that, in his opinion, physical ailment, the difference between a patient with a physical ailment and a mental ailment is that the one with the physical ailment wants to live and the rest want to die. I want your thoughts on that, please, from your experience. Oh, I can't hear you. Sorry. You're on mute, Dr.
Dr. Gaind, you are on mute.
I believe I'm off now.
Yes.
So I'll start with the first part, and thank you for the question, because I'm glad you raised that about some of the context and framing in the bill. I don't agree with that language. When language is put in a public policy document that says that mental illness is not considered a grievous illness, that sends the wrong message. It actually risks, and I do not believe this was intentional, I'm not suggesting it that way, but it does send a message that reinforces a stigma that delegitimizes the validity of mental illnesses. So in terms of that piece of it, my suggestion, and this is actually in one of the points in the brief that I've sent you, but my suggestion was that the current exclusion of mental illnesses from consideration as sole criterion applications for MAID should remain for the reasons that I've spoken to previously. However, the wording should make it clear that this exclusion is based on inability to fulfill a key requirement, specifically of there being no evidence or standards for predicting irremediability in mental illnesses. And the wording should explicitly acknowledge that mental illnesses can be grievous disorders. Now, in terms of the distinction between physical and mental illnesses, it's not about the diagnostic issues. It's largely about what we understand of the underlying etiology of them, the biology of them, the course of them. But in terms of whether physical ailment, like what leads people to seek death from a physical ailment versus a mental disorder, there's a concept in palliative medicine that was brought about quite a long time back by Dame Cicely Saunders, where they talk about the idea of total pain. And by total pain, they don't just mean physical pain. They mean all of the things, including existential pain and angst that people may have. I think we have a similar situation when people are thinking about applying for MAID. It is not about an isolated silo of one type of suffering versus another that leads to these requests. It's about, I think a fair way to say it would be total life suffering. And what I do believe, and this aligns with what Dr. Kim was saying, and there is work that supports this, that when people are suffering heavily from physical illnesses, they have a lot of suffering, but as you expand to mental illnesses, they continue to have suffering from symptoms of illness, but the degree of suffering from psychosocial issues is actually even greater. There are people who literally, when they spoke with the Mental Health Commission during the first round of consultations, I believe it was, there were people who literally said that the stigma I've faced is worse than the illness I've faced. And that tells you something about where the suffering is coming from. So when you combine all of that, you do have to ask, what would people be applying for death for? Is it illness suffering or total life suffering? And to some degree, that gets back to making sure we don't set up a system where we're essentially fooling ourselves, that we've set it up for people to be relieved of irremediable medical condition, illness, suffering, but it's really addressing other life factors that maybe we should be dealing with differently.
Thank you, Dr. Gaind. We will now go to
Thank you very
Senator
much.
From. Senator From. You are muted, Senator From.
Thank you, Chair. Just to follow up on that last answer, which was a very sensitive answer, but having listened now to this whole session, I think is it correct to make a takeaway that the argument is not that mental illness is not a grievous illness, and it's not that there are not irredeemable mental illnesses, and it's also not that every mental illness can be treated. There are mental illnesses that are untreatable and irredeemable and grievous. And I understand the two witnesses to have argued today that because of the inability of doctors to diagnose the difference between which is which, that is why we don't want to venture into this. But we're not saying, I think, or you are not saying, that there aren't irredeemable mental illnesses that are beyond treatment. And I guess the question I have for both witnesses is, in those cases, what are we saying to those individuals who fall into that category?
Who are you referring to, Senator From?
I would ask both witnesses if there's time, because I think this is the argument that they have both made, and I mean it's a very substantial and reasonable argument. But I just want to understand, for those people who do fall into those categories of irredeemable mental illness, grievous illness, untreatable mental illness, what do we say to those individuals?
Dr. Kim?
Thank you, Senator. I think that's a very important question.
Dr. Kim, please hold the microphone to your
mouth. I apologize. I apologize yet again. I have a very short memory. Senator, I think that's a very important question that we have to address. And let me just say that I think that it's because we need to be able to mentally imagine addressing people who are affected by this. And your point really gets at that. And I would say for those people who have what we don't know if they'll never get better. So I think what you mean is people who have chronic illnesses that appear to have very difficult to treat illnesses. We're working very hard, and we wouldn't say untreatable because there's always the how should I put it? The therapeutic relationship which can help people cope and shore up their coping capacity. But let me just add the following. The bigger part of my answer really is not simply speaking to that person, but also perhaps saying to that person, think about all these other patients who would have gotten better, whose lives were cut short, and who we'll never hear from, and for whom we would never have this kind of conversation. I think that can't be separated from the very important question that you're asking, because you all are in a very, very tough situation because you have to consider both of those things, not just one. And, you know, it's a luxury for a scholar to just sort of give you our opinions, but really the tough decision really is think of, and that would be my answer. We have to look at everybody to whom we have to be accountable.
Dr. Gaind?
And you know, I'll actually follow from Dr. Kim's answer, because I think that part of the reason the focus of today's discussion has been so heavily on the issue of irremediability is because that's the criterion that's set out in MAID. We haven't been speaking about these other very important issues. You're right. That doesn't mean that there are not things we can do. So I am going to answer it in two ways. And one is to, again, play off this idea of the balance we need. Because you remember you had Mark Hennick testify earlier in the week. He is a prime example of somebody who was in a situation of dire suffering. And it's very poignant. I don't think he relayed this testimony at the Senate, but he has publicly previously, where he got to a point years ago where he was literally on a bridge, ready to jump. And in the crowd, there was one person who actually said, jump. And there was another one who pulled and held him back. And, you know, he didn't get better instantly. He didn't say that, but that was an eye-opening moment for him. And he decided, I want to be the person who holds someone back, not the person who pushes someone. I want to be the same thing myself. And I used to end some of the sessions I would teach with a bit of a precarious balance, implying that, well, if we get it right, we'll find the perfect tricky balance. I don't end it with that anymore. I now actually have this tricky balance always skewed a little bit, because at the end of the day, it's not, I don't believe, about something where we will ever get the balance right. What we're going to have to ask ourselves is, which mistakes do we want to make? And that is part and parcel of this. Now, for the person who does continue to suffer, we do not abandon them. We don't abandon being with them, and we don't abandon trying to care for them. You would not believe how much difference that can make. A lot of the studies that talk about, you know, do people get better or not, they're so focused on symptoms. They don't talk about the other existential issues that actually lead also to changes in people's lives. And the last thing I'm actually going to read you a very brief quote. This is from the same paper that I referred to you by Dr. Dembo years ago, where she describes that patient who she was certain after multiple suicide attempts would never get better. And if MAID had been available then, I have little doubt that that patient would have likely been interested. But at the end, she writes, both hopelessness and hope can be self-fulfilling prophecies. The former resulting in stagnation, apathy, and suicide, and the latter leading to purposeful efforts and recovery-focused activity.
Thank you, Dr. Gaind. We'll go to the next panel, and if Dr. Kim and Gaind have time to stay on, please stay on, and we do have another panelist, and we want to give her the maximum time. Dr. for being here, and senators, we're going to take a few minutes to about 15 minutes to continue with the previous panel, and I will ask Senatrice Dupuy to now ask Dr. Kim her question.
Madame la Présidente.
Madam Chair, well, on the basis of the question that I put to Dr. Kim, I just wanted to clarify something, namely the statistics that he mentioned in detail on the overrepresentation of women in the Netherlands does not correspond at all to the Quebec experience where there's 53% men and 47% women. I don't want to take up more time. I'll leave the other questions for the Senator. It was just a clarification.
May I address?
Yes, please. Can you take your mic up, please? Can you
Oh,
put
yes. Thank you. Thank you so much, Senator, for that question. That's why I had an entire slide on this point, which is that even in the Netherlands, if you separate out people with psychiatric disorders, the psychiatric MAID cases, it's about 50-50, just as it is in Quebec. As far as I know, all the data up to this point in Quebec do not include, and I don't know any separate data specifically about psychiatric cases. So that was my point.
Thank you, Dr. Kim. Now we'll go to Senator Kutcher and then Senator Pate. And then Senator Carignan.
Thank you very much. Thank you very much, Madam Chair. Question to Dr. Kim. You raised the importance of research in your discussion. A number of your papers on psychiatrist decision-making capacity assessment competencies been made in
Senator
Belgium.
Kutcher, sorry, we can't hear you very well. Can you lower your microphone towards your mouth, please?
Okay, how's that? Is that better?
Yes, it is. Thank you.
Sorry, I had adjusted my headset. To Dr. Kim, you raised the issue of research in your presentation, which is very important. A number of your papers on psychiatrists' decision-making capacity assessment competencies in MAID in Belgium and Netherlands are based on samples of 100 cases and 66 cases, respectively, a small and unrepresentative fraction of the number of persons who have received MAID in those countries. This research was also based on case report review, a technique that we know can't be used to assess psychiatrist competencies. As a professor emeritus myself and a previous examiner for the college, I can attest that competency assessment for any individual psychiatrist can only be determined by multiple direct observations, not by reviewing the case reports. Your research, to my knowledge, has not used this methodology and has not been conducted with Canadian psychiatrists, although Canadian psychiatrists are, by the Royal College competency criteria, demanded to show substantive competency in decision-making capacity assessment and in complex suicide assessment. Given that C7 is a law for Canada and not a law for Belgium or Netherlands, and that how MAID is practiced in Canada is different from that how it's practiced in Belgium and Netherlands, would you think it would be unreasonable for critics to cite your work as proof that Canadian psychiatrists do not have competencies needed to conduct decision-making capacity in persons who have a sole mental illness?
I would say that, first of all, I would like to correct one statement you made that my sample was not representative of people who received MAID. I would just call your attention to the fact that when I did my first study from which I derived a lot of this data, it consisted of nearly 80% of all cases of psychiatric MAID during those years in which it was performed in the Netherlands. So I think close to 80%, as far as these scientific studies go, would be considered a pretty representative sample of the actual practice. The numbers are small because it is the numbers actually available are small. So that is something that we can't do anything about. And I would just point to the fact that whenever you as a scientist would appreciate that the decision making about these issues have to do with the best available evidence, not seeking evidence that's not impossible to get. As you know, there are many randomized clinical trials that we would love to do that we cannot do for ethical reasons or practical reasons and so forth. So it is the same. So the question here is that, do we have the best available evidence given that these are direct cases of the actual cases by the review committees of the jurisdiction in which these occurred and the overwhelming majority of the cases. So I would just point that out. In terms of, I did not say that the doctors are not competent. I said that the practices will lead to inevitable errors. And the question really is the error rate. And I think the important point here is that when you have 20, 30, 40% of the people disagreeing about a particular case, I don't think it's a reasonable position to take that on every single case, the person who found the person not competent is always wrong, which means that there will be obviously cases in which people were not competent who received MAID, and also in cases where people's predictions of irremediability will have been wrong. And I would just like to point out that I was very moved by Mr. LeBlanc's testimony because he and his wife represent a very compelling voice in this debate about why people feel so strongly about it, because they feel that there is this benefit that some people can get. My only point in coming here today and actually trying to use the only direct available evidence that is representative of the practice is because unless we make the a priori claim that there's no harm possible from the practice, then we need to have a cold eye look at what actually happens and the possibility of harm. And the harm would be, for example, people who would receive MAID at age 30 when they could have gone on to live a meaningful life at 60. The only problem is that those cases, once the procedure is done, there's no way we can be accountable to them. And what I'm trying to do is to bring the attention back to a population-based reasoning, taking into account both the benefits, and I think that you've been witness to some of the most compelling reasoning behind that today, but also the less perhaps engaging, because I know I'm a little boring as a researcher talking about numbers, but sometimes we have to look at the numbers to talk about the likelihood of harm and so forth. Thank you.
No, and thank you very much for your clarification. I appreciate that very much. It is, and I'm sure we'll both agree that assessing a person's competencies and even error rates from case reports is very, very, very difficult. And I completely agree with you that it's the ratio of risk of harm to benefit that is the major challenge that we are all struggling to sort out.
Thank you. Senator Kepate.
Thank you very much, Madam Chair. And because I see you're still with us, Mr. LeBlanc, I just want to say thank you for sharing. Please do give our best to your partner as well. And the kinds of decisions you're having to make are ones that too many of us and too many of the people that we are working with struggle with every day. And thank you for your care for Justine. My question for both doctors is, one of the things we're being asked to grapple with here is a situation where we will be inserting in our healthcare legislation the right to die, essentially, when many of us are concerned that we actually don't have the same provisions and the standards that require the provision of social services, health services, and economic supports that you have described create what I think Dr. Gaind talked about, and I don't want, sorry, what I would describe as potentially an unjust, unfair, and unequal position. It's been described as paternalistic to deny people with disabilities the right to die. I'm wondering, I find it problematic to describe as a choice the option of the right to die when we haven't already also enshrined the right to live for far too many people. And I'm wondering if you're comfortable commenting on that component. I think you have it already in some of your testimony, but if you could elaborate on that, I would be very grateful. Thank you.
Sure, yes. So who were you directing the question to, Senator? I'm sorry.
To both of you, actually, if there's time. Thank you.
I can address that briefly first.
Yeah.
Oh, go ahead.
No, go ahead.
Okay. Senator, I think that's a very, very compelling point. As you probably know, there is a strong tradition in political theory where autonomy is the foundational principle, and that is obviously very strong in this right to die movement. However, it is just as strong within that tradition to think about what is true autonomy, which is having genuine options in front of you such that you can truly freely exercise that autonomy. And I think what you're speaking to is that that can sometimes get lost when we when we just look at one, perhaps some of the more compelling aspects. But I would echo that, and that there is a very strong intellectual tradition with which we can make a very compelling case that autonomy demands better.
And I would echo what Dr. Kim is saying and go a little bit further in that, you know, it is an issue of choice. You can't have autonomy without choices. And what a system that's set up to facilitate easy access to death, to provide relief of life suffering, while there are no options or there are not available options for providing life that has relief of life suffering, will naturally skew decisions in a certain way. And you know, what we do find is it's very hard to see changes in national suicide rates. And it's striking how there are some examples through the past several decades where we've seen dramatic changes that seem associated with making it easier or harder to access easy death. The example I'll give you is the coal gas deaths in the UK. So back in probably the 60s, they essentially in homes had domestic supplies that were provided with coal gas that had about 14-15% carbon monoxide. The suicide rates were about I don't remember the exact numbers, but about say 30 per 100,000 for men and about 20 per 100,000 for women. And over the next 10 years, they dropped dramatically, and you almost never see that kind of change, where it went from 30-ish per 100,000 down to 20-ish per 100,000 for men. And similarly for women, from about 20 to maybe 13 per 100,000. And what it seems to have been associated with was simply not having coal gas with carbon monoxide piped into homes. They switched to natural gas, which is not lethal the same way. And you see a similar parallel to some of the suicide deaths in some Asian countries. Similar thing happened in Sri Lanka between the mid-90s to the mid-2000s when they banned endosulfan, which was a common way of killing oneself with easily available supplies of pesticides. So what does that tell us? It shows us that if we do make it easier, it is actually something where more people will do it. And if the other part of that equation is that we do not have the support systems in place for people to live without suffering, what will they do? I think it's pretty obvious. Can I make one small comment on a different issue? I found the dialogue about the ability to make determinations of capacity through just a chart review interesting. With the Chair's indulgence, could I make a brief comment on that?
Yes, go ahead quickly.
Thank you. So again, this actually, I'm glad this came up because it highlights that not just the risk, the danger of lack of standards. The one case, or at least the first case, of MAID for mental illness in Canada that occurred when there was independent judicial review, the Alberta Court of Appeal case of EF, a woman who had conversion disorder. If you recall, in that case, the psychiatrist who opined on it never saw the patient. They did not see the patient visually. They didn't see them directly. They didn't have a phone conversation with them. And yet, not only did they opine on irremediability of conversion disorder, which is when someone has symptoms we can't explain through physical findings, they also opined on this person being capable and competent on a chart review. So Senator Kuchar, I agree with you. It is a risky thing, especially if things like that are brought into clinical practice. And EF did receive MAID.
Could I just make a brief follow addition to that?
Very brief,
very important point.
Very brief, Dr. Kim.
I thank Dr. Gaind for reminding us of that case because it reads very similarly to the kind of, I should say, personal prerogative and discretion that doctors take when they provide evaluations and so forth. And that's not something not to be underestimated, which is different from saying they're incompetent.
Thank you, Dr. Kim. So I have so many second rounds, but I'm giving 1.5 minutes literally to Senator Petitclerc, Senator Carignan, Senator Dalphond, and Senator Batters. Senator Petitclerc. Oh, she is not here. Senator Carignan.
Oui, je veux juste.
Yes, I'd just like to make one point. Did I understand Senator Pate saying that the right to life is not enshrined? I believe that Section 7 of the Charter is quite clear on the right to life. I have a question for the physicians. The concept of mental illness is very broad. When a person suffers from a mental illness, and here I'm leaving aside the physical aspects or comorbidity aspects that may be related to the physical side of things, but are there mental illnesses that can be considered to be irremediable? Is there a mental illness that exists where it's irremediable in nature? Does that exist, that type of mental illness?
So it's a good question, because I think what it gets to the heart of is that we know there are times that people continue suffering through their lives, and cases of the unfortunate cases when somebody ends up taking their own life, for example, naturally by definition, they were in a state of suffering, you would imagine, when they took their life, and they had not remediated. And so it's not that we don't believe it can happen, it can. The problem is, one is identifying it, but the other is also defining what we mean by irremediability, because very often irremediability in our biomedical model focuses on symptoms. And yet patients don't always focus on symptoms. And certainly if somebody has chronic symptoms that persist, one of the things we know, you heard earlier from, I believe, mental health, CMHA, about the value of the recovery model, which puts a different framework on it. I don't want to take all the time of the question in case Dr. Kim has.
Okay, the Senator Dalphond.
Thank you. My question is for Dr. Kim. On his PowerPoint on page 12, he wrote, because of fewer psychiatrists in the Netherlands willing to be involved, 91% of psychiatric MAID now occurs in clinic that only performs MAID, with no relationship with patients, no palliative care, and no other treatment offered. So does that speak for the fact that psychiatrists should try to maintain the link with the patient, especially those that shows that they will be willing to use MAID?
I'm sorry, Senator. I didn't quite understand the last part of your question. Could you repeat it? I'm sorry.
I said your excerpt doesn't stand for the principles that psychiatrists should be invited to maintain the relationship with their patients as much as possible, even when they show sign that they would like to use MAID?
Oh, absolutely. I think whether or not, just like as a psychiatrist, I practiced for 18 years and have had many, many conversations with people who wanted to die. And I acknowledge their desire to die, and we talked about it. And I didn't always hospitalize them when they expressed that, if I thought it was a chronic issue that we had to work together with. And I think it would be horrible if somehow anybody advocated that there should be a severance of relationship between the treating psychiatrist and people who wish MAID, because that's our job, to stand next to people who have those feelings. I should say that the reason why it occurs in the Netherlands is because that either patients find out about doctors who are more willing to do it, so they go to them or the clinics, and they themselves, no, you can't force relationships on people. So, and there are fewer and fewer psychiatrists willing to countenance doing it because for a variety of reasons, actually.
Okay, thank you, Senator
in
Batters.
Canada.
That'll be our last witness, Senator Batters.
Thank you very much. To Dr. Gaind or Dr. Kim, whoever can give me the best quick answer. There was a claim made at least once over the course of our study this week that suicide rates go down in countries that legalized MAID for mental illness. Given your understanding of the assisted suicide regime internationally, in limited jurisdictions, of course, do you have any insight into whether this is in fact true? From my understanding, that's not the case.
I'll jump in very quickly,
Yes.
and I'm going to
Yes.
read you what's from the CCA report directly on this, because I was struck by that comment earlier about suicide rates in Belgium reportedly going down and staying stable in Netherlands. In fact, as the CCA report found, in jurisdictions where psychiatric ES is permitted, OECD data show that on average. Now, keep in mind, there's something after this. The non-assisted suicide rate decreased in the Benelux countries between 1990 and 2016. More recently, the suicide rate has increased in the Netherlands since 2007, while remaining relatively stable in Belgium.
Okay, thank you very much. Appreciate your
Thank
time.
you. Thank you to all panelists.
Sorry, Scott.
Sorry, you can see we could go on all day, but I have to give a bit of a break to the interpreters. To all panelists, I want to thank you for being here, and to senators for being so patient with me today. So thank you so much, and we will we'll meet again at Mark at 12 or 1?
1 o'clock.
1 o'clock, please. Thank you, everybody.
Thank you all.
Thank you. Thank you very much.
Thank you very much, senators.
Thank you.
Appreciated the deep
Thank
discussion.
you very much.
Thank you.
Excellent discussion. Thank you.